Hello everyone, this is Dr. Millie Dogra and I am back again to continue our lecture series on neuromuscular blocking drugs. Today we will be talking about neuromuscular monitoring. The most important indication of neuromuscular monitoring is to exclude residual neuromuscular weakness or paralysis. Ideally, neuromuscular monitoring should be used in any patient who receives neuromuscular blocking drugs. However, there are certain patient populations that are either more sensitive to the effects of paralytic drugs or have altered pharmacokinetics and dynamics of these drugs due to, let's say, the nature of their medical comorbidities such as advanced liver and kidney disease, obesity, neuropathies, neuromuscular junction disorders like myasthenia gravis, and many, many more. However, in many settings, clinicians do not have access to necessary equipments for measuring the degree of block. So, historically, anesthesiologists have relied on clinical tests such as sustained head lift, tongue depressor test, or sustained hand grip test to assess muscle power. Then, the feel of the reservoir bag has been used as an indirect measure of pulmonary compliance, tidal volume, and inspiratory force. However, due to their lack of sensitivity and specificity, clinical tests should not be used to evaluate neuromuscular recovery, especially in high risk patients such as those that have been listed above. So, neuromuscular monitoring involves electrical stimulation of a particular nerve and subsequently recording the response, whether electrical or mechanical. So, the response is recorded, which is produced in the muscle by the said nerve. So, whenever precise information about neuromuscular function is needed, qualitative or quantitative neuromuscular monitoring should be employed. So, let's start our discussion with neuromuscular monitoring. There are a few terms that we should be familiar with before diving into today's discussion. So, first, I would like you to be familiar with something known as the supramaximal stimulus. Now, what is supramaximal stimulus? So, we know that a muscle fiber, a whole muscle actually is made up of individual muscle fibers. So, if we zoom in on this muscle, each muscle is going to be made up of individual muscle fibers. Now, the reaction of a single muscle fiber to an electrical stimulus is going to follow the all or none phenomenon. That means that if the stimulus does not reach the threshold value, then the muscle fiber will not contract. However, if the stimulus is strong enough and it crosses the threshold value, then the muscle fiber will contract maximally. So it is going to show an all or none kind of phenomenon. In contrast to individual muscle fibers, the whole of the muscle, the response of whole of the muscle, which is made up of a number of individual muscle fibers, will depend on the number of fibers that are getting activated. So, if some of the fibers within the muscle get activated, then the muscle will contract, but the contraction will be weaker. And if all of the muscle fibers are activated, then the contraction of the whole muscle will be the strongest. So, if a nerve is stimulated, let us suppose this is the nerve and this is the entirety of the muscle. So if the nerve is stimulated with enough intensity, then all of the muscle fibers within this muscle will get activated and you will get a maximal response. Now, in neuromuscular monitoring, the electrical stimulus that is applied to the nerve is usually 15 to 20% greater than that which is required to produce a maximal response, and that is why it is called as the supramaximal stimulus. So the second term I would like you to be familiar with is calibration. So, calibration of a device used for objective neuromuscular monitoring is essential to ensure that the observed response to the supramaximal stimulus is within the measurement window. Of the device, and it is as close as possible to the 100% of the control value. So even if you have given a supramaximal stimulus, you might not get a response if the recorded response lies outside the measurement window of the measuring device. Therefore, calibration of the device is essential before using it. So calibration is most often done with a 1 Hertz single twitch stimulation. The third term we need to look at is impedance. So what is impedance? Impedance is basically the resistance that is provided to the electrical current by the skin. In neuromuscular monitoring, whenever we have to stimulate a nerve, we generally use a current of 60 milliamperes. Now, if the resistance or the impedance of the skin is more than 5 kilo ohms, then this current which is being supplied to the nerve will not be able to actually make it to the nerve. And therefore, you will not get the response. Therefore, for a maximum stimulation of 60 milliamperes, the maximum resistance of the skin should be 5 kilo ohms or lower than 5 kilo ohms. It should not be greater than 5 kilo ohms. If the resistance or impedance is more than 5 kilo ohms, then you might not get a response with 60 milliamperes of current. In fact, the whole reason of using a supramaximal stimulus is actually to overcome this electrical resistance of the skin, so as to get a response every time despite changes in skin resistance. However, certain newer devices measure and indicate the level of skin resistance on the screen, and in such cases, establishment of a supramaximal stimulus is generally not needed. Another very important concept is of the safety margin. Now, we know that when, this is, let us suppose this is the motor end plate and this is the nerve. Now, on the postsynaptic membrane, you are going to have nicotinic acetylcholine receptors. When 70 to 95%, when 70 to 80% of the total nicotinic acetylcholine receptors on the motor end plate are occupied by the non-depolarizing muscle relaxant, then clinically evident weakness starts to occur. And when 90 to 95% of receptors are occupied by the non-depolarizing muscle relaxant, then complete paralysis will occur. Therefore, the neuromuscular transmission that happens has a significant margin of safety. It means that a significant number of receptors need to be blocked before clinically evident paralysis starts to occur. Almost 70% of the receptors have to be blocked before clinically paralysis starts to occur. Hence, currently available equipment allow insight only into this 70 to 95% range of receptor occupancy. That means that even if the device shows complete recovery, almost 70% of receptors could still have been occupied by non-depolarizing muscle relaxant but no longer detected with neuromuscular monitoring. So this just has to be kept in mind. So now let us talk about the different types of peripheral nerve stimulation. Generally speaking, theoretically, there are only two types of stimulations that can be used. One is the electrical stimulation and the other is magnetic. Electrical stimulation by far is the most common method that is used. Magnetic stimulation generates magnetic currents and this in turn stimulates the nerve. However, magnetic stimulation requires a lot of bulky, heavy equipments and therefore it is generally not used in clinical anesthesia and it is mostly relegated to research purposes. So let us talk about some basic considerations while considering neuromuscular monitoring. So first, let's talk about the stimulating electrodes. Now, the stimulating electrodes, which are ultimately going to stimulate the nerve, they can be either surface electrodes or they can be needle electrodes. So surface electrodes naturally are applied on the skin surface and they are going to stimulate the nerve transcutaneously. Most commonly used surface electrodes are usually disposable pre-gelled silver or silver chloride electrodes. The conducting diameter of the surface electrode should be small and the diameter should range from 7 to 11 millimeters and not more than that. The skin should be prepped thoroughly before applying surface electrodes, so it should be properly cleaned with rubbing alcohol or an abrasive solution. The topmost layer of the skin, which is known as the stratum corneum, is the greatest contributor towards skin resistance or skin impedance. Therefore, skin has to be prepped adequately before applying surface electrodes. The needle electrodes can be used in certain situations where surface electrodes cannot be used, for example, in burns or in obesity. And steel injection needles are placed subcutaneously using a sterile technique. Now, let's talk about the sites of nerve stimulation. Now, one very important thing to be kept in mind while selecting an appropriate size for monitoring is to avoid direct muscle stimulation. Right? That means even if the neuromuscular junction is blocked by non-depolarizing muscle relaxant, direct stimulation of the muscle fibers by the stimulating electrode will still result in a contraction. Although these contractions differ from the ones via the normal neuromuscular route, being characterized by a weaker nature of contraction and the absence of fade. Now, in order to prevent direct muscle stimulation, the prerequisite is that the site of nerve stimulation and the site of subsequent evaluation of the twitch response in the muscle should be topographically or anatomically distinct. And naturally, it makes sense. If the muscle where you need to evaluate the response is in very close proximity to the nerve being stimulated, then there is a high chance that the electrical current which is being used to stimulate the nerve can also flow towards the muscle and therefore cause direct stimulation of the muscle and interfere with the evaluation of the recorded response. Therefore, to prevent direct muscle stimulation, the site of nerve stimulation should be topographically or anatomically distant from the site of subsequent evaluation of the twitch response. Now, the gold standard for stimulation site is usually ulnar nerve. However, other sites can also be used, such as median nerve, posterior tibial nerve, common peroneal nerve, and facial nerve. Now, for ulnar nerve stimulation, the electrodes are applied on the volar aspect of the wrist, right? So, this is the volar aspect of the wrist, and the electrodes are applied on the volar aspect. Now, there are two electrodes, the cathode, which is the negative electrode, and the anode, which is the positive electrode. Now, the distal electrode should be placed approximately 1 centimeter proximal to the point where the proximal flexion crease crosses the radial aspect of the flexor carpi ulnaris tendon. and the proximal electrode should be placed such that the distance between the centers of the two electrodes is between 3 to 6 centimeters. The response that is measured with this placement is going to be the adduction of the thumb due to contraction of the adductor pollicis muscle. Correct. Now, placement of the negative electrode distally is going to elicit the greatest neuromuscular response. Therefore, the negative electrode has to be placed distally, the positive electrode has to be placed proximally. So the nerve muscle unit which is most often used for neuromuscular monitoring is the ulnar nerve adductor pollicis unit. Adductor pollicis unit. So the stimulatory response can be evaluated either tactically. So you can feel for the contraction of the muscle. You can visually see the contraction of the muscle or the adduction of the thumb. Or you can use objective measures, which we will talk about later, to quantify the evoked response. So this nerve muscle unit is going to have the lowest risk of direct muscle stimulation due to the topographic separation of the ulnar nerve and the adductor pollicis muscle. For example, you are stimulating the ulnar nerve at this position, this placement, and you are measuring the evoked response here. So as you can see, there is a good topographic or anatomic distance between the site of stimulation and site of recording the evoked response. So there will be the lowest risk of direct muscle stimulation. Other nerve muscle units that can be used are the posterior tibial nerve, flexor hallucis brevis unit. So here you stimulate the posterior tibial nerve, which causes the contraction of the flexor hallucis brevis, which is going to produce flexion of the great toe. Right, so it is going to flex the great toe. So the third neuromuscular or nerve muscle unit that can be used is the facial nerve. So due to stimulation of the facial nerve, you can actually record evoked responses in two different muscles. First is the orbicularis oculi. The other is corrugator supercilii. So orbicularis oris causes the closure of the eyelids due to stimulation of the zygomatic branches of the facial nerve, and corrugator supercilii causes wrinkling of the brow due to stimulation of the temporal branches of the facial nerve. There is, however, increased risk of direct muscle stimulation because these muscles are located in close proximity to their corresponding nerves. Also stimulation of the facial nerve can be accomplished with significantly lower currents. Like I already mentioned, the usual currents that we use for ulnar nerve stimulation are around 60 milliamperes, but you can do with 25 to 30 milliamperes of currents when you are stimulating the facial nerve. So I have also talked about in a previous lecture about the differing sensitivities of various muscle groups to non-depolarizing muscle relaxants. For example, diaphragm I have talked about is the most resistant of all the muscle groups to the action of non-depolarizers. Similarly, corrugator supercilii and orbicularis oris, all of these are central muscles and they have fast contracting fibers. So they are resistant to the action of non-depolarizing muscle relaxants, which means they require higher doses to produce peak effects. So corrugator supercilii and laryngeal muscles or essentially the vocal cords, are more resistant than peripheral muscles such as adductor pollicis, which are composed of slow contracting fibers. And the most sensitive group of muscles to non-depolarizers are the pharyngeal muscles. This we have already talked about before as well. Now, onset times, however, are quicker in the central muscles such as the diaphragm and the vocal cord muscles. Despite them being resistant and requiring higher doses to achieve peak effect, the onset of neuromuscular blockade is quicker in central muscles such as diaphragm and vocal cords due to higher blood flow and shorter equilibration half times. This also renders the diaphragm and laryngeal muscles prone to quicker recovery as compared to adductor pollicis muscle. Now, response to the corrugator supercilii muscle to facial nerve stimulation reflects the extent of neuromuscular block of the vocal cords better than the response at the adductor pollicis muscle. For example, I have already mentioned that if you have given an intubating dose of a non-depolarizing muscle relaxant, then vocal cords will show onset quicker than adductor pollicis. Now, adductor pollicis is one of the most common muscles that we measure in neuromuscular monitoring. So, if we wait for the complete paralysis at the adductor pollicis, so essentially we do not have to wait for the complete paralysis of adductor pollicis, because even before the adductor pollicis is completely paralyzed, the vocal cords would have already been paralyzed, because the onset of neuromuscular blockade at the vocal cords is quicker than at the adductor pollicis muscle. Right. Therefore, even with a TOF count of 1 or 2 at the adductor pollicis, you can still go ahead and intubate the patient because the vocal cords would have been paralyzed. The alternative is to actually measure the evoked responses at the corrugator supercilii due to facial nerve stimulation. Because they belong to the same kind of fast contracting fibers, the TOF ratios and the degree of neuromuscular blockade at the corrugator supercilii will correspond much more closely with the vocal cords than would adductor pollicis correspond to vocal cords. Right? Now let's talk about patterns of nerve stimulation. So first we will talk about the single twitch. Now, in single twitch stimulation, single electrical stimuli are applied to the peripheral nerve at frequencies which range from 1 hertz, which is every second, to 0.1 hertz, which is every 10 seconds. So as you can see, the topmost panel shows the stimulus, and each stimulus usually lasts for around 0.2 millisecond. The duration of each of these square rectangular waveforms is 0.2 milliseconds, and the frequency ranges from 1 hertz to 0.1 hertz. Generally recommended frequency is 0.1 hertz. So if you take a look at the subsequent panels which have been shown below, these are the responses at the muscle, evoked responses at the muscle. So due to each single twitch, there is a corresponding response in the muscle. Now this arrow corresponds to the administration of the muscle relaxant. The topmost, upper panel is actually showing the response after the administration of a non-depolarizing muscle relaxant, whereas the bottommost panel shows the evoked response after administration of succinylcholine. So this is a non-depolarizing type of a block, and this shows the depolarizing type of a block. Now, as you can see, there isn't a lot of difference between the two blocks. So in the non-depolarizing type of block also, you can see that there is a gradual reduction in the twitch height, and eventually the twitch is going to disappear, or if it's a partial non-depolarizing block, then the twitch height is going to get reduced. And same thing you can see with the depolarizing block as well. After the administration of succinylcholine, there was a decrease in twitch height, and eventually there was recovery as well. The only point of difference between the two is the time factor, because we know that with non-depolarizing muscle relaxants such as atracurium, after you've given atracurium, it takes about 3 minutes for relaxation to occur, and then the duration of action of atracurium is around 45 minutes, which means it is an intermediate acting non-depolarizer, and therefore you can see for almost 30 minutes there has been no increase in twitch height. Whereas in case of succinylcholine, it is a very, very fast acting drug. Therefore, the onset is almost a minute. So within a minute, you can see the full effect or the peak effect, but the recovery starts to happen pretty soon, and after about 7.5 minutes, full recovery has taken place and the person has come out of succinylcholine induced paralysis. But apart from the time factor, you cannot really use single twitch in order to differentiate between non-depolarizing block or a depolarizing block. Therefore, the stimulation pattern does not really provide sufficient information of the type of block and also not on the level of block either. Therefore, in clinical anesthesia, standalone single twitch has limited utility, and it is mostly used as a component of post-technic count, which we will talk about later. Also, it is the okay, we will talk about post-technic count later on. Now let's talk about the train of 4 monitoring, which is the most important type of electrical nerve stimulation that you need to know about. So in train of 4 monitoring, 4 supramaximal stimuli are given every 0.5 seconds. Therefore, the frequency is 2 Hertz. Each stimulus is going to cause the muscle to contract, right? So as you can see here, the first panel shows the control values. So this shows the stimulus. Now you can see there are 4 stimuli in the train of 4 stimulation. Each stimulus is a supramaximal stimulus. It lasts for around 0.2 milliseconds, and the duration between 2 successive stimuli is around half a second or 0.5 seconds. Each stimulus of the train is going to cause an evoked response in the muscle, or essentially will cause the muscle to contract. Now, the basis of evaluation of train of 4 is based on a number of things. One of those is the TOF count. So what is TOF count? TOF count generally refers to the number of discernible responses after TOF stimulation. So you've given the TOF stimulation. How many responses can you see? How many twitches can you see after TOF stimulation? That is called the TOF count. For example, here the TOF count is 4, because after TOF stimulation, all the 4 twitches can be seen. Here the TOF count is 1, because only 1 twitch is seen. The TOF count is 2. Here the TOF count is 3. Here again the TOF count has come to 4. Right? The other thing that you need to know about is the fade. So the middle panel is actually showing a non-depolarizing type of a block. So here you have given the non-depolarizer such as atracurium. After you give the intubating dose of a non-depolarizing muscle relaxant, there is going to be an intense block and all of the twitches are going to be disappeared. So in the first, after giving atracurium in the first panel, here the TOF count is 0. That means there is intense or profound block. Complete paralysis of the muscles has taken place. Therefore, even with TOF stimulation, the TOF stimulation did not result in any discernible twitch responses. So the TOF count was 0. After that period of intense block, there will become a period of deep block, and finally, when you recover the first twitch of the TOF count, then we say that moderate block has been achieved. So this shows the various stages of neuromuscular recovery. Initially, you will recover the first twitch of the TOF count, then the second twitch will be recovered. After a while, the third twitch will be recovered, and then a fourth twitch will be recovered. So all of these are showing different stages of partial non-depolarizing block. So when the fourth twitch actually disappears, then we say that almost 70 to 75% of nicotinic acetylcholine receptors have been blocked by the non-depolarizing muscle relaxant. When the second twitch also disappears and only 2 twitches remain, then we say that almost 80% of receptors have been blocked. And when only 1 twitch remains, that means 3 twitches have disappeared, then 90 to 95% of receptors have been blocked. For surgical anesthesia, for surgical relaxation, the number of receptors that need to be blocked should be anywhere between 75 to 90%. So if your TOF count is anywhere between 1 to 3, then that is adequate for most surgical procedures. You do not need to completely abolish the TOF count. You do not need the TOF count to become 0 for most surgical procedures. There are certain situations where you might need an intense or profound block, where you might have to completely abolish the TOF count. I will talk about it just in a little while, but for most surgical procedures, you do not need to necessarily abolish the TOF count, and a TOF count of 1 to 3 is sufficient for most surgical procedures. So this phenomena is known as fade. Fade essentially refers to the decrease in the amplitude of successive responses. Right? For example, in this panel, you can see the first stimulus of the train resulted in the first twitch, but the second stimulus resulted in the second twitch, but it had a amplitude which was lesser than the first twitch. Similarly, the third twitch's amplitude is even lesser, and finally in this panel you can see the fourth twitch is just tiny as compared to the first twitch. So there is progressive decrease in the amplitude of the successive twitches in as a response of TOF stimulation, and this is known as fade phenomena. And fade phenomena is a characteristic of non-depolarizing type of a muscle block. So fade is not observed with succinylcholine. Another thing that you need to know about is the TOF ratio. So what is TOF ratio? It is simply the ratio of the amplitude of the fourth twitch to the first twitch. So T4 by T1 is known as the TOF ratio. So as you can see, before the administration of the neuromuscular blocking drug, the TOF count was 4 and the TOF ratio is 1, because the amplitude of the fourth twitch is equal to the amplitude of the first twitch. Therefore, their ratio will naturally be equal to 1. Now, during a partial block due to a non-depolarizing muscle relaxant, the TOF ratio becomes less than 1 and progressively becomes smaller. So as you can see, here the TOF ratio is less than 1 and it progressively becomes smaller as the amplitude of the fourth twitch keeps on decreasing. The TOF ratio will progressively become smaller and smaller as the depth of block increases. There will come a point when the fourth twitch disappears. So here you can see the fourth twitch has completely disappeared, indicating that 75% of nicotinic acetylcholine receptors have been blocked. That means it is a TOF count of 3. The disappearance of the third twitch indicates the blockade of 80% of receptors, or a TOF count of 2, and when only one response to TOF stimulation is seen, that means a TOF count of 1, then almost 90 to 95% receptors have been blocked. During the phase 1 block, which is produced by scoline, all the 4 responses to TOF stimulation are decreased equally. So the TOF ratio will always remain 1. No fade is seen and the TOF ratio will remain 1 despite the level of depolarizing block. If you see that after administration of succinylcholine you are able to see fade phenomena, then that means that you are entering a phase 2 block, which is not a good thing, right? This is also a good time to revise the grading of the depth of neuromuscular blockade. Now, neuromuscular blockade actually can be divided into various grades. For example, we have intense or profound blockade, deep blockade, moderate blockade, light or shallow blockade, minimal blockade, which is near recovery, and then finally full recovery or normal function. Now, I have already mentioned. Okay, another thing to keep in mind is that once the fourth twitch disappears, the TOF ratio will become 0. And then you cannot use TOF ratio to quantify the depth of neuromuscular blockade. Then you'll have to go for TOF count, because TOF ratio can only be quantified when the fourth twitch is present. When the fourth twitch becomes absent, then there is no point of calculating a TOF ratio, because if the amplitude of fourth twitch is 0, then your numerator becomes 0 and your TOF count becomes 0. Right? So, in the intense or profound block, your TOF count is 0. This I have already mentioned. Once you give an intubating dose of a non-depolarizing muscle relaxant, you completely abolish all sorts of responses to all patterns of electrical nerve stimulation. So the TOF count becomes 0. If your TOF count is 0, naturally your TOF ratio will also be 0, because there won't be a fourth twitch. In a deep block, the TOF count is again 0, but the TOF ratio is also 0. Right? Under moderate block, which is the level of block which is suitable for most surgical procedures, the TOF count is between 1 to 3. Right? And the TOF ratio will again be 0, because there is no fourth twitch. If the fourth twitch is not there, the TOF ratio cannot calculate the TOF ratio, it will be 0. Then in a light or shallow block, the TOF count will be 4. Now all the four twitches have been recovered. So now you can calculate the TOF ratio. But in a light or shallow block, the TOF ratio will be less than 0.4. And in minimal block, which is near recovery, again the TOF count is going to be 4. The TOF ratio will be more than 0.4 but less than equal to 0.9. And in full recovery, that is normal neuromuscular junction transmission and function, the TOF count is naturally going to be 4 and the TOF ratio will be more than 0.9. And at this position or at this state, the patient is safe to be extubated. So your TOF ratio has to be more than 0.9 for you to consider extubating the patient. So we will fill in these things a little bit later on as we continue to read about more patterns of electrical nerve stimulation. So for now, you need to quantify or grade the depth of neuromuscular blockade based on TOF count and TOF ratio. So most surgical procedures can be done in moderate block. So you don't need to completely abolish the TOF count. You can keep the TOF count between 1 to 3. But for certain surgeries, when even the slightest cuffing or bucking cannot be tolerated, for example, head and neck surgeries, neurosurgeries, vascular surgeries, we do require a deep or maybe even a profound level of block. But as you can see, the TOF count and TOF ratio in deep and profound block is 0. Therefore, it becomes difficult to monitor the depth of blockade and recovery with TOF when the patient is in a deep or intense block. In such situations, you will have to make use of PostTnic count, which we will discuss in a short while. Also, when used continuously, an interval of at least 10 seconds should be allowed between each set of TOF stimulation. 10 to 12 seconds should be given before each set of TOF stimuli. So what are the advantages of TOF? So the advantages is that it is less painful than your normal Technic stimulation, and you can differentiate between the non-depolarizing type of a block and depolarizing type of a block, and you can also identify phase 2 block of succinylcholine using train of 4, and it is one of the most commonly used patterns of electrical nerve stimulation. What are the major disadvantages of using TOF? So the major disadvantage is that the tactile or visual assessment of TOF is only reliable when the TOF ratio is less than 0.4. Now again, let us move on to this table. Will you be able to feel or see fade phenomena when the patient is in an intense or profound block? No, naturally no, because there is no electrical response in the muscle. Therefore, if there is no electrical response, there is no way that there will be a mechanical contraction either. So there will be no fade that is seen. So same with the deep block, no fade is going to be seen in a deep block either, right? And what about moderate block? Again, no fade will be seen. What about light or shallow block? So when all of the 4 counts have been recovered and the TOF ratio is less than 0.4, then the fade phenomena can be seen either visually or tactically, right? So TOF ratio, or rather TOF pattern of stimulation, is good to observe the fade phenomena, but only at lower levels of TOF ratio or lower values of TOF ratio. When the TOF ratio becomes more than 0.4, that means at higher TOF ratios, the fade phenomena, either visually or tactically, cannot be really appreciated using TOF stimulatory patterns. So when the TOF ratio becomes more than 0.4, the fade will not be seen. So this is one of the disadvantages of using TOF, is that the tactile or visual assessment of TOF is only reliable when the TOF ratio is less than 0.4. Between TOF ratios of 0.4 and 0.9, fade cannot be observed tactically or visually, and objective monitoring is required to further quantify neuromuscular recovery and exclude residual paralysis. Second disadvantage of TOF is that TOF stimulation does not allow the clinician to quantify deep or profound block, as I've already mentioned. And finally, TOF stimulation does not allow monitoring of depolarizing phase 1 blockade, because fade is not seen with phase 1 block. So now let's move on to the double burst stimulation pattern. Now in double burst stimulation, we give 2 short bursts of 50 Hertz Technic Stimulation, which are separated by 750 milliseconds with a 0.2 millisecond duration of each impulse in the burst. So as you can see here, you are giving 2 short bursts of Technic Stimulation. So the frequency of each burst is around 50 Hertz, right? The duration of each single stimulus is around 0.2 millisecond, and the 2 bursts are separated by a period of 750 millisecond. Now there are 2 modes that are available in DBS, or double burst stimulation. You can have DBS 3.3 or you could have DBS 3.2. Now in DBS 3.2, there are 3 impulses in the first burst, separated by 750 millisecond, and the second burst is going to have only 2 stimulations. Whereas in DBS 3.3, both the bursts are going to have 3 stimuli. So the individual twitch response, as you can see, this is the stimulation and this is the response. So the individual twitch response that are elicited by each burst actually blend together and are felt as a single muscle contraction, right? Therefore, the response to double burst stimulation, what will you see once you've given a double burst stimulation? What are you actually going to see? So the response that you are going to see is 2 muscle contractions, and the presence of fade in the second contraction with respect to the first contraction forms the basis of evaluation of double burst stimulation, right? So DBS 3.2 has been shown to be superior because it has higher sensitivity of detecting fade as compared to DBS 3.3, especially at higher TOFs. The major disadvantage of double burst stimulation over TOF is the tactile or visual detection of fade is better observed. The major advantage of DBS. In fact, actually, the double burst stimulation was developed in order to compensate for the lack of fade that was seen with TOF at higher TOF ratios. Therefore, double burst stimulation was developed in order to make fade phenomena better appreciated visually or tactically at higher TOF ratios. But the major disadvantage, or rather not even disadvantage, see, double burst stimulation cannot reliably rule out residual neuromuscular blockade between TOF ratios of 0.6 to 0.9. Now we know that at TOF ratios of less than 0.4, the fade can be seen with TOF as well, TOF stimulatory pattern as well. But when the TOF ratio becomes more than 0.4, the fade disappears visually or tactically with TOF stimulation, but it is still present with double burst stimulation. But even while using double burst stimulation, when the TOF ratio becomes more than 0.6, then even double burst stimulation cannot reliably exclude residual neuromuscular paralysis. So when the TOF ratio is, let us suppose, 0.8, the obviously neuromuscular junction has not yet recovered, because full recovery is marked by a TOF ratio of more than 0.9. So at a TOF ratio of 0.8, there is residual neuromuscular paralysis, but you might not be able to see fade even with double burst stimulation. Therefore, double burst stimulation cannot replace objective neuromuscular monitoring. And the fourth stimulatory pattern is actually, or rather whatever, fifth stimulatory pattern is the Technic Stimulation. So here we give a 50 Hertz Technic Stimulation for 5 seconds duration. The response is one strong sustained muscle contraction, and fade after the Technic Stimulation is the basis of evaluation of non-depolarizing block. This why fade happens, what is the basis of fade, this I have already talked about extensively in great detail in a previous lecture, for which I will provide a link in the description. But suffice to say, fade is actually a presynaptic effect. We know that the neuromuscular junction is comprised of a presynaptic neuronal membrane, the synaptic cleft, and a postsynaptic muscle membrane. On the postsynaptic membrane, you have the postsynaptic nicotinic acetylcholine receptors, which can be alpha 2, beta, delta, epsilon, but they are also present prejunctionally, and they are known as prejunctional nicotinic acetylcholine receptors, which are generally alpha 2, beta 3 receptors, right? And they are responsible for modulating the acetylcholine release in response to Technic stimulation. That means when there is repeated electrical impulses that are coming in, there is mobilization of vesicles which contain acetylcholine, which actually cause, for example, let us suppose if Technic stimulation are coming in, this will cause more and more acetylcholine to be released at the synaptic cleft. Now naturally that acetylcholine is going to interact with the postsynaptic nicotinic acetylcholine receptors, but some of that acetylcholine is also going to interact with the presynaptic nicotinic acetylcholine receptors. Once these presynaptic receptors get activated, they cause mobilization of vesicles which contain acetylcholine into the readily releasable form of these vesicles. Therefore, more acetylcholine is made available for release, and more acetylcholine is released at the synaptic cleft. Now, non-depolarizing muscle relaxants not only block the postsynaptic nicotinic acetylcholine receptors, but they also block the presynaptic nicotinic acetylcholine receptors, and thus limit the acetylcholine release in response to Technic stimulation, thus making subsequent muscle contractions weaker and weaker and weaker, which is essentially your fade phenomena. So, Technic stimulation has little use in everyday clinical anesthesia except as a component of either double burst stimulation or post-Technic count. Now let us move on to the post-Technic count stimulation. In post-Technic count stimulation, we give a Technic stimulation of 50 Hertz for 5 seconds. This is actually followed by a gap of 3 seconds, after which 10 to 15 single twitches are given at a frequency of 1 Hertz. And these are known as PTC twitches. So here we have given a Technic stimulation of 50 Hertz for around 5 seconds. There was a gap of 3 seconds, and then we gave 10 to 15 single twitches. In this example of illustration, out of the 10 to 15 single twitches that were given, only 4 produced responses, right? So this is actually a response. The stimulation will look something like this. So a Technic stimulation at 50 hertz for 5 seconds, followed by a gap which actually, so this actually is showing a no depolarizing type of a block. That is why there is no response to the Technic stimulation, because the muscle is paralyzed. But after the Technic stimulation, during the gap of 3 seconds, there is post-Technic potentiation. Post-Technic potentiation. What is post-Technic potentiation? I will talk about it in a while. But after a gap of 3 seconds, we give single twitches at a frequency of 1 hertz, 10 to 15 single twitches. So out of these 10 to 15 single twitches, in this particular example, there are only 4 responses that are seen, and therefore the PTC count here is 4, right? So this is based actually on the post-Technic potentiation. So what is post-Technic potentiation? Now, post-Technic potentiation, basically after a Technic stimulation, a lot of acetylcholine is going to be released in the synaptic cleft, as I previously mentioned. Now, this abrupt increase in acetylcholine concentration at the synaptic cleft is going to briefly shift the ratio of acetylcholine and the non-depolarizing muscle relaxant at the motor end plate in favor of acetylcholine. So, even if no twitch was discernible before the Technic stimulation, noticeable muscle contraction can still occur after Technic stimulation. Now, during intense, so let us again move back to this table. This is a very important table. So, during an intense or deep block, only post-tetanic count stimulation allows for assessment of neuromuscular function. For example, during a deep block, when both the TOF count is 0 as well as TOF ratio is 0, there is post-tetanic count of more than 1. So, if your neuromuscular monitor, during neuromuscular monitoring, you see that the TOF count is 0, the TOF ratio will naturally be 0, but you switched over from TOF to post-Technic count pattern of stimulation, and you saw that the post-Technic count was, let us suppose, 2, then you can safely say that the patient is in a deep block. If even the post-Technic count is 0, then the patient is said to be in an intense or a profound block. So in an intense or profound block, there is absolutely no electrical evoked response to any pattern of electrical stimulation, whether it be Technic stimulation or TOF count or post-Technic count. Everything is 0. But during a deep block, there is a post-Technic count, right? For maintaining a deep level of block, so if you want to keep the patient in a deep block, that means you have to you want to ensure complete paralysis of the diaphragm. It has been suggested that the post-Technic count should be kept below 3. So if your post-Technic count is kept below 3, then you can maintain a deep enough block. As the post-Technic count approaches 10, then the return of the first twitch in the TOF count is imminent. So your patient is going to come out of deep paralysis and go into a moderate paralysis, right? PTC stimulation cannot be applied continuously, and at least 6 minutes should be allowed between post-Technic count stimulations. So I hope all of these various stimulatory patterns are clear. I have tried to make it really illustrative and simplified. If you have any questions or any doubts regarding this, please do let me know in the comments, and I will try to simplify it further. Now let us talk about the equipment that we use. So the the device that is used for neuromuscular monitoring should be capable of generating a stimulus that produces a monophasic and a rectangular waveform. Right? And the length of the pulse or the duration of the pulse should not exceed 0.3 to 0.2 to 0.3 millisecond. If the duration of the stimulus is more than 0.5 millisecond, then there are high chances of direct muscle stimulation. The nerve stimulator should also be able to generate a current of 60 to 70 milliamperes, but not more than 80 milliamperes. The polarity of the electrode should also be indicated, and it should be able to deliver a variety of stimulatory patterns such as TOF, DBS, and PostTnic count. Peripheral nerve stimulators, such as those which are used for nerve blocks, only allow for stimulation of the target nerve. Right? The response of the muscle has to be measured through tactile or visual means only, and therefore it is impossible to reliably exclude residual neuromuscular paralysis by using peripheral nerve stimulators. For objective neuromuscular monitoring, you have to use specialized equipment. So let's talk about the objective monitors. Now, there are several methods that can be used for objective neuromuscular monitoring. We have MMG, which is mechanomyography, where we measure the evoked mechanical response of the muscle. We have EMG, which is electromyography, where we measure evoked electrical responses of the muscle. We have AMG or acceleromyography, where we measure evoked acceleration of the muscle. We have KMG or kinemyography, where we measure evoked electrical responses in a piezoelectrical film sensor which has been attached to the muscle. There is cuff pressure modality, where we measure the pressure changes in blood pressure cuff after contraction of the upper arm muscles. We have compressomyography, where we measure the pressure change of a spherical balloon which has been put in the hand after hand contraction. And we also have phonomyography, where we measure low frequency sounds which are produced by muscle contraction. So these two are generally not available for clinical use. Only objective monitors which are currently available are based on the AMJ, EMG, CPG, and KMG. So MMG is mostly used for research purposes, and KMG, CMG, and PMG are also used for research purposes only. They are not available clinically. Now let's talk about mechanomyography or MMG. So mechanomyography actually measures the isovolumetric contraction. If you remember your physiology lectures from MBBS, muscle contraction can be of two types. It can be isovolumetric and it can be isotonic. In isovolumetric contraction, the muscle is contracting, but the length of the muscle remains the same. And this leads to an increase in the tension within the muscle. Whereas in isotonic contraction, the length of the muscle shortens as the muscle contracts, but the tension within the muscle remains the same. So mechanomyography measures the isovolumetric contraction. A prerequisite of measuring isovolumetric contraction is that a specific amount of preload has to be applied on the muscle, which prevents the shortening of the muscle in response to muscle contraction. So it is going to measure the isovolumetric contraction of a muscle after stimulation of the corresponding nerve. So in order to achieve isometric conditions, a preload of 200 to 300 grams has to be applied to the thumb. So if this is the thumb, so the ulnar nerve is stimulated, and there is actually going to be a sensor that is attached here, a preload that is attached to the thumb, and this preload and the thumb is then going to be attached to a force displacement transducer. Which actually converts the tension which is being generated within the muscle into electrical impulses, and these will be proportional to the amount of tension being generated, which will in turn be proportional to the amount of response that is evoked in the muscle secondary to stimulation of the ulnar nerve. So, MMG is considered to be the gold standard of neuromuscular monitoring. However, it is mostly relegated to research purposes because of relatively cumbersome equipment needed to perform. Now, electromyography, it is going to record the compound action potential that is generated in the muscle due to stimulation of its corresponding nerve. Most often, the ulnar nerve is stimulated and the evoked EMG response is obtained from the thenar eminence of the hand. There have been two new sites that have been introduced, the larynx and the diaphragm, although they are more for clinical research. So I will not be going into details for them. The advantage of EMG is that the equipment is easier to set up and the response can also be obtained from muscles that are not accessible for mechanical recording, such as vocal cords and diaphragm. Then we have acceleromyography. Here it measures the isotonic contraction. So MMG was measuring isometric contraction. AMG is going to measure isotonic contraction. So it measures isotonic acceleration and it is based on Newton's second law, which states that the force is product of mass and acceleration, right? So greater the force generated by the thumb, more will be the acceleration, and therefore more will be the, or rather if so more the acceleration that is produced by the thumb, because when you are measuring AMG, the thumb has to be freely moving. You cannot fix the thumb. This is in contrast to MMG, where you had to apply a preload. In AMG, the thumb has to be freely moving. So as you stimulate the ulnar nerve, the thenar eminence or the adductor pollicis muscle will contract, which will produce acceleration in the thumb. Greater the acceleration, greater will be the force generated, and more will be the electrical stimulation that will be recorded by the AMG. So it is going to use a piezoelectric ceramic wafer with electrodes on both sides. Now, a very important note that you should note about AMG is that the measurements which are made via AMG, they are not directly comparable with the results that are obtained via MMG or EMG. So when AMG is used with a free moving thumb, then the AMG control TOF ratio is higher than when measured with a force displacement transducer of a MMG. What this means is that when you are talking about adequate neuromuscular recovery in terms of MMG or EMG, then the TOF ratio of more than 0.9 signifies adequate neuromuscular recovery. But if you are measuring your TOF ratio via AMG, then adequate neuromuscular recovery is given by a TOF ratio of more than 1 and not more than 0.9. So just you have to keep this in mind. The next is kinemyography. So kinemyography is essentially based on the principle that stretching or bending a flexible piezoelectric film, for example, one that is attached to a thumb, in response to a nerve stimulation, is going to produce a change in the voltage that is proportional to the amount of stretching or bending. Then we have cuff pressure modality, and here so if this is your upper arm, the blood pressure cuff will be applied to the upper arm. Now within this blood pressure cuff are going to be electrodes which are incorporated, and they are going to stimulate the brachial plexus at the level of the humerus. And this will cause contraction of the bulk of the muscle of the upper arm. As the muscles of the upper arm contract, they are going to generate a pressure change in the cuff, which is going to be analyzed and displayed in the monitor. Now let us talk about the evaluation of evoked responses in case of non-depolarizing neuromuscular blockers. So what happens during an intense block? Now after giving an intubating dose of a non-depolarizing muscle relaxant, the intense block occurs within 3 to 6 minutes depending on which type of non-depolarizer you have used. So more potent the non-depolarizer, more slower will be its onset. So during this phase, no response of any kind can be elicited by any pattern of nerve stimulation, right? So an intense block is characterized by a TOF count of 0, a TOF ratio of 0, and even a PTC count of 0, right? So an intense block cannot be antagonized by neostigmine. So no matter how much dose of anticholinesterase you give, if the patient is in an intense block secondary to non-depolarizing muscle relaxant, it cannot be reversed or antagonized by neostigmine. And the intense block which has been produced by steroidal non-depolarizers such as vecuronium or rocuronium, it can be reversed by only very, very high doses of sugammadex. The doses of as high as 16 milligrams per kg would be required to reverse the intense block produced by vecuronium or rocuronium. So if you've given rocuronium to the patient and you realize that you cannot intubate or ventilate the patient and you need to rapidly reverse the patient, naturally immediately after giving rocuronium the patient would be in an intense block. Therefore you would require very high doses of sugammadex as high as 16 milligrams per kg in order to reverse the effects of rocuronium, and it will still take 2 to 5 minutes for complete neuromuscular recovery to take place. Then what happens in deep block? So in a deep block, this is going to follow an intense block. So a deep block is characterized by the absence of TOF count. So TOF count will be 0. TOF ratio will also be 0, but there will be some post-tetanic count, right? At least one PTC will be present. To avoid diaphragmatic movement and ensure a deep blockade, you have to keep the PTC count below 3. So you have to keep PTC count below 3 in order to keep the patient in deep blockade, right? So again, deep block cannot be reversed by neostigmine. And if you need to reverse a deep block produced by vecuronium or rocuronium, you require sugammadex in the dose range of 4 milligrams per kg. If you need to monitor neuromuscular function in case of intense or deep block, you cannot use TOF and you can use post-tetanic count stimulation to monitor neuromuscular function in case of intense or a deep block. Now, what about moderate block? So this begins when there is recovery of the first twitch on the TOF count, right? So it is characterized by a TOF count of 1 to 3. Since the fourth twitch is absent, the TOF ratio is still 0. During this phase, there is good correlation that exists between the degree of block and the number of responses to TOF stimulation, which I've already discussed. For example, if there is just one TOF count, then that means 90 to 95% receptors are occupied. If the TOF count is 2, then that means 80% receptors are occupied, and a TOF count of 3 means that 70 to 75% of receptors are occupied. The presence of 1 or 2 twitches normally indicates sufficient relaxation for most surgical procedures. In general, reversal with neostigmine should not be attempted until all the 4 twitches have been recovered. So once all the 4 twitches have recovered, then only you should give neostigmine. When neostigmine to reverse, let us suppose atracurium, is given at a TOF count of 3, then it takes approximately 16 minutes for the TOF ratio to reach more than 0.9 and for the patient to be safe for extubation. The antagonism of moderate block due to vecuronium or rocuronium can be achieved by using 2 milligrams per kg dose of sugammadex. So if you need to reverse VEC or ROC, in case of intense block, you need to give 16 mg per kg of sugammadex. In case of deep block, you need to give 4 mg per kg of sugammadex. And for moderate block, you need to give 2 mg per kg of sugammadex. Right? So, how to use neuromuscular monitoring in daily clinical practice? So, what should you do before induction? So, before induction, careful cleaning of the skin has to be done. Proper prepping of the skin and proper placement and fixation of the electrodes needs to be done. Efforts should be taken to prevent cooling. So, cooling should not be there, both central as well as of the extremity being monitored. Central and peripheral cooling can lead to decreases in twitch height and TOF ratio. In addition, peripheral cooling can also affect nerve conduction. It can decrease the rate of release of acetylcholine and muscle contractility. It can increase skin impedance and also reduce the blood flow to the muscles. Therefore, hypothermia should be avoided. And what should you do in during induction? So, nerve stimulator should be attached to the patient before induction, but it should not be turned on until after the patient loses consciousness, because obviously it is uncomfortable and painful for the patient. While seeking supramaximal stimulus, a single twitch can be given at 1 Hz. Once the supramaximal stimulus has been ensured, the device should be calibrated before injecting the relaxant. Newer devices, however, have automatic calibration modules. Now, if the intubation is to be performed using a non-depolarizing muscle relaxant, the patient can be intubated at a TOF count of 1 to 2 at the adductor pollicis muscle, or a TOF count of 0 at the corrugator supercilii muscle. This I've already discussed previously as well. So during surgery, after an intubating dose of non-depolarizing muscle relaxant has been given, a period of intense and deep block follows. PTC or post-technic count can be used during this period to monitor the depth of blockade during intense and deep blocks. For most surgical procedures, it is not necessary to have a deep or profound block, and a moderate level of block with 1 to 2 twitches on TOF is sufficient. And what about reversal? So I've already talked about it before as well. Neostigmine should not be given till all 4 twitches have been recovered, right? And with Sugamadex, reversal of vecuronium or rocuronium in intense block can be achieved with a high dose of 16 mg per kg, in deep block with a dose of 4 mg per kg, and in a moderate block with a dose of 2 mg per kg. It takes approximately 2 to 5 minutes after Sucamadex administration for full neuromuscular recovery, and extubation should only be attempted when the TOF ratio becomes greater than 0.9. And during recovery, the TOF ratio, when the TOF ratio is going to become more than 0.4, all the 4 twitches are going to be seen. It gets difficult to see fade visually or tactily with TOF. Here, double burst stimulation can be employed. So this concludes our lecture on neuromuscular monitoring. I hope this was helpful and beneficial to you. I will be talking about residual neuromuscular paralysis in a separate lecture, because that is a very important topic, both theoretically as well as clinically as well, because a lot of the times we are not using neuromuscular monitoring in the OTs, and we are relying on clinical signs and symptoms to assess residual neuromuscular paralysis, which has a very low sensitivity and specificity. So a lot of the times patients are being extubated well below the recommended TOF ratio of more than 0.9, and it has been found that in 60% of cases, 80% of cases, the patients were being extubated at a TOF ratio of less than 0.6. So at a TOF ratio of less than 0.6, all of the pharyngeal muscles have not yet recovered. The protective airway reflexes might not be there. So there would be high risk of post-extubation respiratory distress and residual neuromuscular paralysis in the PACU area. So I will be covering residual neuromuscular paralysis in a subsequent lecture. Thank you.